Abdominal examination. History. What in the history is going to make you think of doing an abdominal examination? I suggest some of those elements up there. If they talk about pain or discomfort in their abdomen, if they talk about bloating, sense of fullness, from an osteopath's point of view, you might get somebody coming in to say, I've got difficulty bending, so I think there might be something wrong with my back, so I'll come to see you. But is it something wrong with their back, or is it that there's something that they're trying to bend over in their abdomen that's stopping them? So you might need to kind of laterally think about what they're saying. Does what their interpretation of it actually make sense to you? Because if you do have some kind of mass in the abdomen, it's not going to let you go forward very easily. And that mass could be a tumour, it could be what we've just been talking about, an aneurysm, it could be the distension caused by the fluid build-up that we just saw. So any of those sort of things might make you think of an abdominal cause. Anorexia. That is the literal meaning of the word, loss of appetite, not the eating disorder, anorexia nervosa. If they don't want to eat, then there may be an abdominal reason for that. Nausea and or vomiting, constipation and or diarrhea, and the changes in their ability to urinate. Are they having to go more or less frequently, very urgently? Is it more difficult? Is there any change in colour, smell, or any other characteristics of their urine time? And any kind of bleeding from either end of the system. So any of those are going to make you think about an abdominal exam. Things that you might see, antalgia, are they hunching over to try and ease the pain of their abdomen? Edema we talked about before, distension, clubbing, all these things that we talked about before. So any of those observation things might draw you to an abdominal exam. Just a bit of a reminder as to what's in there. It's useful to have an idea of the location of the various bits and pieces. And the way that people describe the abdomen. The old way used to be this kind of noughts and crosses grid crossing it with these named areas. Then they went to this thing where you just draw a line across through the umbilicus and talk about the right and left, upper and lower quadrants. I understand now that the medical schools are coming back to the old way. So if you're looking at somebody else's notes, you might see either of those methods used. So it's useful to be familiar with that so that you can interpret it if you need to from other people's notes. So the idea was to simplify it, but now they seem to be going back the other way. So I'll leave it to you to which one you choose to use. I still think if you want to put it in your notes, it's quite useful to use the umbilicus as a reference point and just sort of measure along and up or down, so that if you're writing to anyone, they've got a clear indication of what you think in terms of centimetres, rather than just saying it's the right upper quadrant or whatever. That is that's the noughts and crosses grid, if you like. laid over the abdomen, so you can see what is in which square of the noughts and crosses grid, which is kind of interesting. I'm not suggesting that you remember all this, but I put that up there just to make it clear the kind of differential diagnoses that might be involved. So if you've got pain in the lower right quadrant, it isn't necessarily appendicitis. Everyone thinks it is. And actually appendicitis is quite difficult to diagnose. But there's all these sort of things that would need to be considered by whoever's got the responsibility of coming to a final diagnosis of that thing. So it's a little bit more complicated than most people think it is. When you're doing abdominal examination, one of the first things that you might want to do is have a listen, auscultate. When you listen to the abdomen with a stethoscope, every 10-15 seconds or so, you should get a kind of gurgling noise, and that's called borborygmus or borborygmia, which is the normal digestive process going on. If that doesn't happen, it's an indication that the peristaltic transit has stalled. And that is a fairly serious issue and needs to be addressed. So if you suspect from the history that the patient might have some kind of stalled digestive transit, it's probably best to have a listen before you start prodding around. Because if you want to know what it's like when the patient comes into you, and if you play around too much, you might change it. So if you think you need to listen to the abdomen, do it first rather than later. Where do we listen? You can really think about ascending, transverse, descending colons, and the small intestine in the middle. Anywhere around here, you can kind of move your stethoscope to see where you best pick up the borborygmia sounds. You might be interested in auscultating arteries within the abdomen as well. If you listen to an artery which is healthy and carrying blood normally, you won't hear the blood, because the blood flow is laminar and it's only turbulent blood flow that makes a noise. Because when you're doing blood pressure, if you clamp the artery off and no blood flows, you don't get a noise. If you listen to the artery when the blood is flowing normally, you don't get a noise. When you've clamped it off and you partially open it, you hear the pulse in there because you're hearing turbulent blood flow. So if you are suspicious of any kind of blood supply issue to the kidneys or around the ilia or the aorta, if you have a listen to those areas, you would normally expect not to hear anything. But if the arteries are slightly occluded, or if there's an aneurysm, then you may find that you can hear the blood flow in there, or a kind of whooshing noise in there. And the noise of turbulent flow in an artery is called a bruit, B-R-U-I-T. in the specific case of heart valves, turbulent flow in the valve is called a murmur. So a heart murmur is turbulent blood flow through a heart valve.
Could I just ask, when you're listening for the digestive sounds, where do you put your stethoscope first, or do you do a couple of different places?
I think if you think about the way that the intestines go, you've got this middle bit, which is where the small intestines are, and then you've got the large colon ascending, transverse, and descending going down there. So I would just move it a few places around centrally. If you hear anything, just go towards it and see where it turns out. There's no kind of geometric, you listen here for it, you need to sort of spread it around a bit. The other thing that we normally talk about with the stethoscope, you know, there are various types of stethoscopes now, but the standard one has got the bell and the diaphragm, and you can change it from one to the other. Then they talk about the diaphragm picking up higher frequencies and the bell picking up lower frequencies. I've always been a bit confused about what counts as high and what counts as low on the body. So what I tend to do is move it around. If I hear something, and I try it with the other side and see which one makes it sound clearer to me. So I think I do the same sort of thing with that. Yeah. If it's you're probably more likely to get a slightly lower sound for the borborygmia, so I'd probably try with the bell. Although, if you read the books, they say just before the colon kind of stalls completely, you get more noise because the system starts churning a bit to try and force it through whatever the obstruction is. And at that point, you can get a higher frequency sound. But to be honest, I think that's more relevant to doctors who might be checking patients hourly in hospital. The chances of the patient coming in to see you at the very moment that their system is about to go into this sort of stasis phase is pretty remote, I think. So I think I'd just be inclined to do a general scan of it and try both sides just to see what we talked about the aortic aneurysm before, but that's an actual one which has been present in a patient that's obviously been examined post-mortem. You can see the sort of size relative to the artery there. Oh, the other thing about the aortic aneurysm, which I put on there, the aorta's got 3 layers of tissue making up the tube. And what sometimes happens with these these aneurysms, is that the inner lining splits and the blood forces its way under that and then runs back up. So it's kind of stripping the lining, the inner lining off the middle part. And that's, patients will or may report that as a tearing sensation, that they'll feel it as though it's tearing back up towards the heart.
What causes the split of the internal line? Is that like cholesterol or worry?
I think that's one of those things that they don't really know, because the one theory is that yes, you've got too much cholesterol and that causes a weak point. The other question is that the damage exists and the body covers it with cholesterol as a kind of plaster to try and heal it. So I think it depends who you listen to, what goes on there. If you listen to the people that favour the idea that the cholesterol is the body's healing response rather than the cause. The original thing is often damaged due to poor nutrition, lack of vitamin C, things like that, that cause the lining of the artery to be less compliant than it should be, and therefore more likely to damage. But I'm not sure that there's a hard and fast answer to that. The current medical feeling still seems to be that too much cholesterol is the cause of the problem, but some of the later work seems to imply the other way around. The other thing that you can use a stethoscope for on there, if you think that the stomach is not empty as it should, maybe because there's an obstructed pyloric sphincter, then what you can do is put the stethoscope on around that epigastric area, hold it with your thumbs and just shake the patient from side to side and see if you can hear a sloshing around. Your stomach empties of liquid fairly quickly normally, so if that was done at a reasonable time after they'd had any kind of drink, then you wouldn't expect to hear that sloshing around. If you did, it might confirm your suspicion that the stomach was not emptying properly. And that's called succussion splash. Succussion just means shaking. So, landmarks of the abdomen. Obviously, we're going to use the umbilicus, the ASISs, the costal margins, the appendix is located, if you draw a line from the umbilicus to the right ASIS and then measure 2/3 of the way along there, you arrive at the point where the appendix is, well, being more precise, the base of the appendix, the root of the appendix is actually attached to the cecum. The appendix is worm-shaped, and it kind of can go back and hide itself behind the cecum. So sometimes surgeons have a difficult job finding it. But where it attaches to the cecum is at that point there, or deep to that point there, and that is called McBurney's point. You would expect that to be tender in appendicitis, but as we said before, that's not the only thing that can be wrong. Yeah. Do you want to stop now? Yeah, okay. I'll just do the gallbladder and then we'll stop for a break, if that's all right. So, if we're looking at the gallbladder, the point for that is called Murphy's point, and we've got a couple of ways of finding that. If you find the rectus abdominis on the right-hand side, follow the lateral border of that up to the costal margin. That is Murphy's point, and that's where the gallbladder is. And another way of finding that is if you go to the left ASIS and draw a line straight up through the umbilicus, that points to the same spot. And that area is likely to be tender if there's a gallbladder issue. That's called Murphy's point. And there's a thing called Murphy's sign. I'll just set that right. I haven't got a slide for Murphy's sign. Murphy's sign is if you were to gently but fairly deeply palpate over Murphy's point, and maybe the patient would let you get in there, and then you've got the patient to breathe in, if the gallbladder was sensitive, when the patient inspires, the diaphragm pushes the liver and the gallbladder down towards your palpating finger. If that's going to cause pain, they're not going to continue that breath in. So they might go and catch. That catch in the breath is called Murphy's sign, because they don't want to keep the breath going that's going to cause them pain. So that might be a way of trying to incriminate a gallbladder issue. Finding our way around the abdomen, it's useful to know where the liver and the spleen are. This picture's a little bit misleading. If you think of the liver more or less coming around coincident with the costal margin, around there, and the spleen is tucked away inside the rib cage on the patient's left-hand side, and it's behind the anterior axillary line between ribs 9 and 11. So it's well up inside the rib cage there. The liver is also mainly behind the rib cage with just this border. Think of it as being more or less along the line of the costal margin. Some people it's just slightly proud, and other people it's slightly back behind it. In the main, you can't easily palpate the liver unless it's enlarged. But some people, it's just a little bit proud of that line. So what we can do to try and find where they are and make sure that they're where we think they should be is use percussion. And it's, if you like, it's a primitive form of sonar. It's echo sounding. So we place one hand flat like that on the patient. Try and take up as much slack as you can. If you're not closely in contact with the patient, you lose a lot of the energy in that sort of moving your own fingers about. If you place your hand flat, spread your fingers, and you're going to tap this bit of this finger with the end of your other middle finger. Like that. Visualise you're sending a pulse through the patient, not just stopping where you hit. And you're listening to the sound it makes, but also feeling for the feedback you get from that hand. And the sound you get is dependent on actually what's underneath. It's really measuring the amount of air that's under there. If you get a solid organ like the liver, there's virtually no air in it at all. So tapping like that gives you a kind of dull, flat note. If you were to percuss somebody's lungs, where there's quite a lot of air in there, you get a much more resonant note. It's a bit like tapping a drum. The more drum-like an area is, the more resonant the sound you get out of it. And what we're really doing is just comparing where we've got resonance and where we've got dullness, and that then gives you the border of what you're trying to achieve. So I've said all that. And dullness can also be caused kind of artificially. If you get it naturally dullness with a solid organ, but if there's a mass there, like a tumour, that's going to sound dull. And if there's fluid in there, that's going to sound dull as well. If you listen to, or if you read the textbooks, they talk about dull and stony dull and things like that. I find that's a little bit complicated for us to get our heads around as osteopaths. I think if you worked in a hospital ward, you'd probably pick up the nuances of these things and think just by the sound of it, you can argue that's fluid and that's a mass. I think from our point of view, if we just distinguish between resonant and dull, and then we'll cover how we decide whether it's a mass or fluid in a minute. I'm sure you can get those nuances, but it's a bit like asking a doctor to feel someone's neck. We can do it and think, oh yeah, there's a facet there. A doctor probably wouldn't pick that up. It's what you tune into. So when we're going to do the abdomen, you're going to be doing something like that. You can see the hands splayed well out, good contact. If you press down so that your fingers blanch out slightly, you know you've got the right sort of contact there. And then you're going to percuss in. And you're going to start away from the area. So if we were, the guy's liver's going to be up here somewhere, so we start percussing away from it over an area we'd expect to be resonant, work towards it and see where the resonance changes into dullness. So liver's in here. If it enlarges, it's going to go down that way. So we cuss from there going up towards there. The spleen is under here, as I said, behind the anterior axillary line and in the rib cage. So it's going to enlarge down this way, and the spleen is going to be about the size of the patient's clenched fist. So imagine that in there. For you to be able to feel that in front of the costal margin, that's got to enlarge about 3 times. So you're never going to feel it if it's enlarged twice, but you can cuss and get an idea of the borders. On that lady that I told you about earlier with the lymphoma, once I'd been given the diagnosis, I percussed for the spleen, and it was about twice the size that you'd expect it to be. Yeah.
If it enlarges that size, would you definitely get referral pain to the shoulder, or not necessarily?
Never say never, never say always. You could do. So with the spleen, you're going to start from I just realised I've got that wrong on the notes there. It says enlarges down from right to low left. It doesn't. It's on the left side and it enlarges down towards the right. I'll have to change that on there. But it's going to be in there on the left side and it's going to tend to enlarge down that way. So you're going to be percussing from this area up towards there. Just make sure you're away from it. What causes enlargement? Various illnesses can cause the liver to enlarge. Spleen tends to get enlarged when there are obstructions to the blood supply, portal hypertension, that's high blood pressure in the hepatic system. If there's an obstruction to the portal vein, perhaps caused by a tumour occluding it, that tends to make the spleen have difficulty getting rid of the blood that it's got in it, so it enlarges in there. It will enlarge with lymphoma because it's a lymphatic tissue. Both these organs can be affected by cancers and by rheumatological conditions as well, and by blood chemistry. So any of those can cause enlargement of these things. The spleen is quite a vulnerable organ, and if it is enlarged, it's got a lot of blood in it. If it's enlarged, it becomes even more vulnerable, a bit like a balloon would. If you overfill the balloon, it's more likely to burst. So if you do have a patient with an enlarged spleen, do suggest that they kind of don't put themselves in the market for being knocked around too much, because you don't really want it to be damaged. And again, because there's so much blood in it, if the spleen does develop a leak, as it were. That blood's got to go somewhere. So that's percussion. We can also palpate the abdomen, and we suggest that you use one hand to receive the information. So we talk about listening with your hand, and use the other hand just to apply gentle pressure. And you're going to palpate all around the abdomen, making sure that we cover all those areas that we talked about, the quadrants or the noughts and crosses grid. You cover everything. If the patient is reporting pain, it's as well to start as far away from the pain as you can. Don't immediately prod the painful bit, because you want your first contact with the patient to be non-threatening and comforting. So get them used to you in an area where it's going to be comfortable, and as you approach the area you can watch their reaction and make sure you're not going to take them by surprise. And what are you looking for? You're looking for any lumps, bumps, pulsations that shouldn't be there. Also, is the patient getting very wary? Are they apprehensive? If they know as you approach an area they're frightened of being hurt, then that should be a clue to you. If the body doesn't really want you there, the muscles will often tense up. They call that guarding, and it's almost pushing you off. If you've got an area where there's been some inflammation and it's progressed a bit, you might find there's an overall rigidity there that you can't get in anyway. The whole thing's borderline. Before it gets to that, there might be areas that are tender to palpation, possibly tender to deep palpation first and then becoming less so. And there's also this thing called rebound tenderness. If you think of the peritoneum a bit like a trampoline, sometimes you get a situation where there's a bit of inflammation in one of the organs, and it will tolerate you pressing around the abdomen without too much trouble if you're doing it gently. If you take your hand off quickly, like that, the peritoneum sort of boings a bit like a trampoline does, and that boinging can irritate the area of inflammation. So the sudden withdrawal of palpation pressure, say over here, might produce pain over there as due to this rebounding effect of the peritoneum. So that's called rebound tenderness. And while you're over there, be aware of any kind of lumps or masses that might be over there, which may not be painful, but you may clock the fact that there's a lump there that you don't think should be there. And what we normally suggest is that you go round once lightly, just to kind of map the area out and get the patient's confidence, and then go round again more deeply. But always being aware by keeping an eye on the patient's expression, whether you're causing them discomfort or not. So that's the sort of suggestion you use. In that case, the operator's using the right hand as the sensing hand and the left hand just to apply a bit of pressure on whatever suits you. And of course you can use it in other ways. Midwives will often use palpation around there to try and work out where the baby is, which way around it is. So if we're going to try and see whether we can feel the border of the liver and spleen, and in the main these would be organs that have enlarged. You do exactly the same as we did for percussion. Start away from it. Gently get the patient to exhale and gently put your hand into a degree of fairly deep palpation. Then get the patient to inhale and the diaphragm pushes the organ down towards you. Can you feel the border? If not, exhale again, move up a bit towards it, then inhale again. So you're creeping up towards it and see if you can feel the border. If you can, can you describe it? What are you feeling? Is it hard? Is it jagged? Is it soft and fatty? If you can feel the border of the spleen, bearing in mind what we said before, that it's going to be 3 times bigger than it should be for you to feel it. The spleen's got a notch in it. So if you feel something, can you feel a notch? If it is, it will be the spleen.
If the liver or the spleen's enlarged,
Yeah.
are they often getting a lot of abdominal discomfort?
The difficult word is often, because you get people react individually, and I suppose in a sense it's how much room there is in the abdomen to take up the slack. They could be. They may not be aware of it. You know, when I said right from the start, they might come to you, they're having difficulty bending forward. It may be that under certain circumstances they feel something that shouldn't be there, but they might attribute it to something else.
If they're having problems bending forwards, is it normally anterior pain or posterior?
It might not even be pain, it might just be a sense of blocking. Yeah. Sorry to be vague, but the problem is that these things don't come in textbook presentations. They will come within an individual presentation. One patient might feel it as a fullness or a discomfort, and other people might describe it as a pain, or they might have other words for it. It's as well to try and get the patient to describe in their own words what they're feeling, and then see if you can make sense of it. But not everyone reports the same thing, that's what I'm trying to say. Yeah, so we've said all that. And then the next bit, I'm not going to spend a lot of time talking about hepatitis, which I sometimes do with the students. I'm sure you know enough about hepatitis and you can look it up anyway. Let's get on to doing some practical stuff, okay? What I suggest we do is break into small groups on a couch, and then we can practice what we've covered this morning. So your scenario is that you've taken the case history. From the case history, you've decided that you need to do an abdominal exam, and you're going to do the examination starting from the extremities, working up each limb, around the face, around the head, onto the throat, onto here, onto the abdomen, then percussion to locate the border of the liver and the spleen, and then some palpation around it. And I'll also call up the slide in a minute about blotting the kidneys, which it wasn't on there, or it must be out of order, but we'll talk about that as well. And there is this technique of blotting them, which I must admit is, I think, largely wishful thinking, but we'll show you what it goes like. If I come here and under there, and then come in here, what I'm doing is moving my hands like that and trying to get a sense of something about like a plum just inboard of my lower hand, because the kidney is retroperitoneal, it's quite posterior in the abdomen, and you're trying to get a sense of how it's moving. Now bear in mind, most of the kidney is up behind the rib cage. All you're going to feel, if you feel anything, is a bit of the lower pulse, and the one on the right is going to be hanging lower than the one on the left, so it might be more easy to do that. But that technique there is called blotting. And if I play around there, I'll put you on it there. That's a bit uncomfortable, isn't it? Yeah. Often the patient can feel that you're on it rather than you can. The way I interpret this, it's a bit like us saying, if we feel somebody's neck, you scan it through and then something jumps out of your attention and you think, oh, that facet is irritated there, I'll do something about that. You're not feeling the facet, you're feeling the tissue changes around it. And I think what you're doing with this is the same sort of thing. That if you've got a problem here, if you get localised onto there and you feel something, it should draw its attention to you by that tissue change thing, and the patient isn't going to like it either if there's a problem. So between the two of you, you know something's going on. But to me, it is a little bit of a a non-specific test. But if you look in all the clinical methods books, it's in there, and it's called balancing. Yeah, I'm going to bump my hand, is that okay?
Oh, yeah.
Now, she's not going to like this very much, like that. It's not very pleasant to have done anyway. If she had a kidney problem, she'd like it even less. Okay. Again, I'm not too convinced of that one, because if she had a 12th rib problem, it's going to hurt as well. I'm repeating what I see in clinical methods books, so you make your own decisions with it.